Okay. Good morning, everybody. It's quite some time that I've talked with you. I'm happy to be here today. Today we are going to talk about something that is very germane to our babies and ourselves. Something that can cause a lot of distress and pains at times. But when it turns out well, can bring joy to our family. I pray that all of us will have a very successful outcome of all our pregnancies in Jesus' name. We want to welcome all our mothers again to this platform. I want to believe that it's been very educative and useful to all of us. Wherever you are joining us, you are welcome. My name is Olarewaju, Raphael, and I'm a consultant gynecologist and obstetrician. Today we talk about premature rupture of membranes and premature preterm labor. Preterm rupture of membrane and preterm or premature labor. The first thing we're going to discuss will be premature or preterm rupture of membranes. And then secondly, we take premature labor. Something was added before, which is pre-eclampsia and eclampsia, but I think it will be too much for one day. Therefore, we'll take the first part today, premature rupture of membranes and premature labor. I want to believe you are hearing me. If you are hearing me, can you please say good morning?
Good morning, sir. I can hear you.
Good morning, Doctor.
Good morning, sir.
Oh, that's very good. There are some terms I want us to be conversant with. One is premature rupture of membrane, what we call PROM, or premature rupture of membrane. Then there is preterm rupture of membranes. Preterm rupture of membranes. And the third thing is prolonged preterm rupture of membrane, or PPROM, prolonged preterm. Usually when they abbreviate is premature rupture of membrane is called ROM. Preterm rupture of membrane is PROM, and prolonged preterm rupture of membrane is PPROM. Now, what are these membranes we are talking about? When the baby is they are surrounded by what we call membranes. They are in a sac. It's like you have this pure water nylon and you have something inside it, and it's sealed as they seal pure water. That is, when the baby is forming, babies are surrounded by this membrane, this sac of tissues that we call membrane. They are usually part of the tissue that form the baby. Because when there is fertilization, that is when the egg and the sperm meet, some cells will differentiate to form the baby proper. Some cells will differentiate to form the placenta. Some cells will differentiate to form this covering sac, and those are the membranes. That's just the simplest way of putting it. And it is these membranes that seal the baby inside the womb and seal the baby from outside, that prevent infection from getting to the baby. Rarely, infection can actually penetrate through the cervix. You know, from the cervix to the vagina, the female genital is actually opened outside through the vagina. An infection can come in through the vagina. Therefore, these membranes sealed the baby in a sac, as it were. Now, when that membrane breaks before labor, it's what we call preterm premature rupture. When it breaks before labor, because inside this sac of membranes, you have the baby, you have the umbilical cord through which the baby is getting the food from the baby mother. You have the placenta on one side, and then you have the fluid that surrounds the baby. This fluid is what we call the amniotic fluid, because those membranes, if I want to tell you what they are made of, is what we have what we call chorion and we call the amnion. The chorion is outside and the amnion is inside. Therefore, this fluid inside is secreted by the amnion and the baby's product, especially the baby's urine and secretions from the mouth, from the throat, and sometimes stool and things like that. Therefore, that fluid is produced by the membrane, and also it is absorbed through the membrane. But when this membrane breaks, the fluid leaks out, and that's how you know. Now, what is premature rupture of membrane? Premature rupture of membranes is said to occur when the membrane ruptures before labor, before the onset of labor, after the 37 completed week of pregnancy. Now, let me explain it again. There is, the duration of pregnancy is 40 weeks in the human beings. The normal duration of labor, of pregnancy, is 40 weeks. Now, the baby is said to be term, that it is mature from 38 weeks. The baby is said to be term, the baby is mature, the baby is fully formed, the baby is ready to be living outside from 38 weeks. Therefore, any membrane that ruptures after that time, 38 weeks to 40 weeks or to 42 weeks or any time, without the mother being in labor, is what we call premature rupture of membranes. Now, what is the preterm rupture of membrane? Preterm rupture of membranes occur when the baby has not reached the term, the period we call term, that is 38 weeks. Any pregnancy that is less than 38 weeks, that is 37 completed weeks or 38 weeks, and the water is draining out, is what we call preterm rupture of membranes. Now, the third one that I say you should pay attention to, whether the baby is term or the baby is not term, is the prolonged rupture. There is prolonged rupture of membrane when the water has started leaking out more than 24 hours and there is no labor. The mother is leaking, the water is leaking out, that is amniotic fluid, that is the membrane has ruptured for over 24 hours without the onset of labor. That is prolonged rupture of membranes, prolonged after 24 hours of rupture. Why is this important? Because of the possibility of infection. When the membrane has ruptured for more than 24 hours, there is the possibility of infection. Infection is higher than if the membrane has ruptured than less than 24 hours before the onset of labor. Now, what are the causes of premature rupture or preterm rupture of membranes? What makes the membrane to rupture at term is actually not completely understood. But there are some factors that have been noticed in some of these people who have prolonged or preterm rupture of membranes. Let me just tell us that normally what happens is that when a woman is in labor, that is, you're having contractions and the cervix starts to open, if the membrane ruptures at that time, it's perfectly normal. And for many of us, we have noticed that the doctor will actually come to break the water because the membrane does not rupture. When the doctor examines you, or the midwife, when they examine, and they know that the cervix has started to dilate and the membrane is bulging, is fed during examination and is bulging, they rupture it so that it can facilitate labor. It allows the presenting part to descend and presses on the cervix and make contraction more effective. That's the normal thing. But what makes that process to occur before term is not completely understood. But some of these factors that I will mention. It is said that there is a programmed cell death at term. You know, the cells that surrounds the baby and the just time of labor and things like that, they have been programmed to last for a certain time. And when it is that, when the time reaches, that is 40 weeks, then some things set up automatically. That one is there. That's the programmed cell death. Therefore, the point where the water begins to leak has been programmed to die at a certain time and becomes weak and begins to leak the water. That's one. But also, it's been discovered that there are some chemicals that are released in some of these women who have this, especially who have recurrent premature rupture or preterm ruptures. There are some chemicals that have been released that is higher than in other people. Also, some of these people have infection. There is inflammation around the cervix and around the area where the leakage occurs. When there's infection, when there's inflammation, there are inflammatory changes and chemicals are released that weakens the nature of the tissue that forms the membrane. Also, it has been noticed that when there is mechanical pressure, when there is tension in the womb, the membrane can rupture. In situations like where there are multiple pregnancies, where the pressure of the fluid is high itself, like when you have excessive fluid, polyhydramnios, where there are some anomalies that will make the baby not to absorb the water and pass it out as urine. All those things can increase the tension in the mother's womb and cause premature rupture of membranes. Also, when there are irregularities in the womb, like when you have fibroids, when there is weakness in the cervix, and there is the chances of the membrane pointing towards that weakness, especially in the cervix. It's like comb, it's like funnel. At the point where there is that pointing, the tension there is higher, and the membrane can leak, can rupture prematurely. This premature rupture of membrane or preterm rupture of membrane is also common in some certain people. We don't know, maybe there are chemicals that are released or there are some processes that are set in motion. People with low socioeconomic factors, we don't know, maybe because of stress of one thing or the other. Low socioeconomic factors is commoner among poor people, is commoner among the poor. That's why the rate of premature deliveries in what they call the third world or developing country is more than, far more than those in developed country where things are, they are more established and the economic status is better. It is commoner in those women who smoke. If you're smoking during pregnancy, it is commoner to have premature or preterm rupture of membrane. It is commoner among those who drink alcohol or who use drugs like marijuana and things like that. Some people do this. It's commoner. It's commoner in there. Therefore, those are some of the factors that make premature rupture of membrane and preterm rupture of membrane to be common and seen in the hospital. Now, how do we know or how do we diagnose this condition in the hospital? I want to advise you, when you begin to see water at any time during pregnancy, it is not a good sign and we need to go to the hospital. When the pregnancy is term, it is better. It means that labor may be coming very soon and you're about to deliver. You're about to see what you have been waiting for. But if it's premature, it will be still very small, or if it has occurred before, especially in those who have recurrent abortion, especially late abortion, then it could be an ominous sign. Therefore, we need to go to the hospital quickly because there are some conditions that occur with this that we need to be very, very careful about. And of course, when we get to the hospital, we must be able to tell them when this leakage begins to come. And I want to warn us, we don't have to wait until some people will say they see gush of water. You don't have to wait until you see gush or you see water just flowing out uncontrollably before you go to the hospital. It could be that you are just feeling wet, especially when you are term, or when you're about 34 weeks and above. You're just feeling wet in your private part, or you just see some fluid that you think is not your urine, then you need to go to the hospital because it could be the leakage of this fluid. The reason is because, as I told you, the chances of infection is very high, especially when it's getting to a prolonged rupture. You see some people in the hospital, they have been seeing water, feeling wet for a week or more, and they still sit at home, they are waiting for labor. That is not a good thing. Therefore, when you get to the hospital, the doctor will take history, of course, ask you, and of course, they will examine you. And apart from doing the general examination, they check your private part. The doctor is not likely to be putting fingers immediately because we don't want to introduce infection and we want to see what is actually happening before you use other things to change the condition. Therefore, what we usually do is to pass a speculum. We pack a speculum. Speculum will enable the doctor to see the vagina and to see the cervix, especially. And when you look at the cervix, you want to see, is there any water? Is there any pool of water anywhere? Is there any odor? Because some people, they have been draining this water and they are already infected. And you find there's, foul smelling things coming out. Then you want to see if the cervix is dilated, if the person is already in the process of labor. Therefore, you want to do that. And then there are some things that you can use to test. If you see water, you want to see, okay, is this ordinary water? Is this water? Is this urine? Is it the body secretion? Is it cervical secretion? Or is it actually the liquor? There are some chemicals that can be used. So in some places, they can look at it under the microscope and see it with what we call frenning. They will clump together. Or you use something they call lateral stick test. Or nowadays, there's something we call amniotic, if it's still available. It's available, they can use it to test if that fluid is amniotic fluid, amniotic. Then when the doctor has done that, they may have to take swab, especially if it's preterm. You want to take a swab from the cervix, and then you want to take a swab from the vagina and from the rectal area, anal area, to see the infection, the organism that may cause infection, so that if you need to be using antibiotic, you know the right one to use. You want to know the right one to use. Therefore, the doctor will do all those when they do examination. And they may send you for ultrasound to see if there is still water around the baby. You know, during ultrasound, this water is seen, that's what we call amniotic fluid. I'm sure if you notice the ultrasound report you have, you see a place when they say amniotic fluid volume, and they will say maybe adequate or low or high, you know. Amniotic volume, you look at it, and then you'll be able to determine the age of the baby. You will know, of course, the part of the baby that is coming out, what we call the presentation of the baby. And of course, we will know where the heart rate and heartbeat, whether or not it's regular and all those other things. Of course, the mother, we would like to know if the mother is febrile, if you have fever, if you are shivering and things like that. Those are evidences of infection, evidences of infection that we want to guide again. And that one may make you to use, to commence antibiotics immediately. Then after you have done all this, and we now make a firm diagnosis that, yes, you are draining liquor, depending on the age of the pregnancy, the doctor will now institute management. If the pregnancy is term, that is 38 and above, of course, go and deliver. They may induce labor immediately. If the presentation is normal, that is, if the baby is coming with the head, the baby is normal, your pelvis is adequate, everything is okay, you are ready to deliver, you have not had operation and things like that before, then they may induce labor and you deliver. But if there are other things that will make vaginal delivery not to be feasible, then they will tell you, and of course counsel you as to the mode of delivery. Therefore, there is no hard and fast rule. It depends on the individual. What you do depends on the individual. That is the mode of delivery. Now, if the pregnancy is preterm, if it's below 38 weeks, but usually if it's 35 weeks and above, yes, they will facilitate delivery also. Because the babies that are 35 weeks, 36 weeks, 37 weeks, they are mature enough to live outside the body without undue complication if there are no other problems. Those babies' lungs are mature enough to stay outside, even not, you may not need incubator. But if it's 28 weeks, 30 weeks, 32 weeks, and things like that, then those babies, they are small, they are premature, as we say, which means that they are small. 1, 2, their lungs may not mature. The lungs are not mature to stay outside the body. Therefore, the problem of respiration or breathing will be there. 3, they cannot breathe. Apart from breathing, they cannot eat on their own. Therefore, you need to provide a special place for them to, special food, a special way of giving them the food. 4, they cannot maintain body temperature. And that's why you may have to keep them inside the incubator, where you regulate the temperature as if they are still in the mother's womb. Therefore, the size, the temperature, the feast, the feeding, the breathing, and of course, infection. Some of those babies, if there is infection, you need to treat aggressively. And then you want to also, they cannot fight infection because they are small and their immunity is not well developed also. Those are the problems with prematurity. And then in that case, you want to see if you can gain a few days more or a few weeks. And therefore, you may resort to conservative management. Conservative, that you want to wait and give the baby chance to mature, to grow more. The best incubator is the mommy's womb. And I say it again, the best incubator is the mommy's womb. And that is why God makes a woman to be the landlord for the baby for 9 months, so that the baby will have every chance to deliver. By the time you take that baby out before 9 months, there are there are other things that come up. There are other things that usually come up. Therefore, you may resort to conservative management. And what do you do in conservative management? You want to, one, make sure the mother is all right. Two, you want to make sure that the baby also is not in danger. That the baby is not in danger. Therefore, you want to prevent infection, as I say, because that's critical, which means that you will monitor the mother and monitor the baby. The mother must be able to know whether or not, you must be able to tell us every day, maybe you have fever, maybe you perceive odor around you, maybe the fluid is now becoming infected. Therefore, fever, shivering, odor, and the water still coming out, and things like that. And then the doctor will be screening you, take your blood to check if there's evidence of infection, do a white blood scan, do CRP, what is C-reactive protein, to see evidence of infection. Of course, I've told you they were taking swab when you first came in for presented in the hospital. You want to see which type of organism those swabs will grow. And then you want to monitor the baby's heartbeat. If the baby's heart rate is going up, that may be evidence of infection. Or the mother's pulse going up, that may be evidence of infection. And at any point where you know that there's infection, you must determine whether the condition inside is now worse than the condition outside, so that you make a decision about how you are going to deliver that baby. Apart from that, infection in the baby, infection for the mother can be so dangerous, especially causing endometritis, infection in the endometrium, and if you are not careful, jeopardize future chances of pregnancy if it blocks the tube. That's why we don't want the mother also to be infected. You want to prevent infection. You want to make sure that the mother is not in danger, the baby is not in danger. And at any point when you sense any danger, you want to make effort to deliver the baby. Two, you want to make sure that you help the baby's lung to mature. And therefore, you may have to give some injections to the mother that will help the baby's lung to mature. In the hospital, they usually give detamexate or betamethasone, whatever it is, to help the baby's lung to mature. Even if it's 48 hours, 72 hours, just that one will help the baby, the lung to mature before the baby comes out. And at any point that you sense danger, you will terminate this conservative approach and then determine how you are going to deliver the baby. At the time you do a VE, I want to tell, of course, the doctor will make sure that there's no cord puller, that the umbilical cord is not coming out. That's one of the reasons why I say we should present in the hospital on time, so that they will see, especially if it's not the head that is presenting, assuming it's the breech or the baby is transverse, the umbilical cord can come out without water. And that's why one of the reasons why you should be careful also. Now, after you have delivered the baby, then you want to counsel the mother about what to do if it's something that is preventable. For those who have uterine anomaly or have fibroid or have cervical incompetence, they may have to deal with things like that before the next pregnancy, before you deliver next time. And of course, bed rest is so important, you know, in our environment, in our conservative management. Rest, especially when we administer you in the hospital. It is to make sure that you are actually resting. Now, I think we should briefly discuss premature labor before we take our questions. Our time is fast spent already. Premature, what is labor? Labor is spontaneous, regular contraction of the maternal womb, of a pregnant womb, that leads to the delivery of the baby. It is spontaneous. Sometimes you can induce it. It is regular. It is recurrent contractions of the pregnant womb that usually leads to delivery, especially after the viability, the time the baby is viable. In our environment in Nigeria, any contraction and delivery that occur before 28 weeks is still known as abortion. Though, thank God, medical science has advanced some part of the world now that a baby of 23 weeks, 22 weeks, 24, 5, and 6, they are already surviving. In our nation also, babies of 25 weeks, 26 weeks have survived in some hospitals, but it's not very, very common. Therefore, the law still says 28 weeks. Any contraction that leads to expulsion or delivery of the baby after 28 weeks is labor. Now, just like rupture of membrane, we have term labor and we have premature labor. Any contraction that leads to expulsion or delivery of the baby before 37 completed weeks is a premature delivery. It's premature delivery. Now, what causes premature labor?
What happened?
Can you hear me now?
Yes,
Hello?
sir.
Yes, we can. Yes, we
Sir,
can.
can hear you now.
Okay, you can hear. Yes. Okay, thank you.
Yes, we can hear you, sir.
Okay, thank you very much.
Yeah.
We are talking about premature labor. Now, what are the causes? Those things that will cause premature rupture of membrane can actually make labor to occur before time. Therefore, we should bear that in mind. That one will include premature rupture of membranes itself, or preterm rupture of membranes, and all these factors that I say may cause them. Premature labor also is commoner, as I said, in the developing country, in the third world, among the low socioeconomic people, than other developed country. And that's why we deliver more premature babies in a year. And many of these babies are wasted just because of our low socioeconomic factors. Now, what happens in premature labor usually is, just as I told you, when you are managing premature or preterm rupture of membranes, preterm rupture of membranes. Therefore, when you start to drain the water, or you begin to have pains, regular pains, recurrent pains, or recurrent contraction, regular contraction that is now painful, after 28 weeks, you need to go to the hospital. In fact, I will say anytime in pregnancy, you need to go to the hospital. But if it's after 28 weeks in this country, that one has become labor. And of course, by the time you get to the hospital, what we do for those who have preterm rupture of membrane is exactly what the doctor will do. They will take your history, examine you, take your vital signs, see if you have fever, check your blood pressure, then examine the baby, and of course, examine your private part, because that is where the baby will come out from, and check whether or not you are in labor. If you go there also with premature contractions, all these steps that were taken for premature rupture, preterm rupture of membrane will be taken. The swab will be taken, the fluid that I talked about will be looked at, and the doctor also will institute management depending on the age of pregnancy. Any pregnancy that is 35 weeks and above, you don't need to keep that woman in the hospital and stop contraction, because the babies are mature enough to be delivered, to live outside the womb. The lungs are mature, the babies are big enough usually, and they are easily handleable. You can easily handle them and feed them more than the very, very premature ones. But the very small ones, below from 28 weeks, say to 33 weeks, those ones will definitely need incubator care. And the doctor will have to determine when to deliver and the mode of delivery. All those ones are not what we discuss in this forum. The doctor will determine that when and mode of delivery. And if there is a reason for conservative management, the baby also will have to be looked at. The mother will have to be monitored to make sure there is no infection that will jeopardize your lives or that of your baby. And then the use of corticosteroids also may be instituted to help the baby's lung mature. And in this case, effort may be made to stop the contraction if there are no contraindications. One of the contraindications is if the baby is, if the cervix has dilated, excuse me.
Okay,
Beyond, if the cervix has dilated beyond what can be stopped, if you are in active phase of labor, that is 3 centimeters and above, they may not stop it. 2, if you are already draining liquor and infection, they will not stop that labor. But if you are just beginning to have contraction, the baby is okay, the cervix is closed, then there are some drugs that can be used. Excuse me, please. That can be used to stop these contractions. And of course, the doctor will make sure that the mother and the babies are okay. I think we should stop here so that we have time to, we still have about 15 minutes more. We have time to ask questions. Do we have time? Do we have questions so that we can raise it or issues that we want us to discuss?
My responsibility.
See Dr. Olarewaju.
Yes, ma'am.
Oh, that's mommy.
Sorry, I can't hear you. Hello? Hello? Sorry.
Hello, sir.
You. Oh, yes, ma'am. I can hear now. Hello? Hello?
Hello, sir. Can you hear me?
Yes, I can hear you now, but I wasn't hearing you before.
Yes, sir. My own question is based on I'm actually 34 weeks and I've been stooling for some days now. I've been stooling like almost every day. So I don't know if what could be the cause of the stooling. Why am I stooling, watery stool every day? And I'm actually 34 weeks.
Okay, pregnancy does not make people to stool.
Okay.
Usually, pregnancy will cause constipation.
Okay.
Because stooling or passage of watery stool can actually induce premature contraction.
Okay.
And for the baby to, there are some chemicals that are produced that make your intestine not to move fast when you are pregnant. And therefore, what is making you to be stooling now, you may have to do with your diet. I think you should watch you should examine what you are eating now.
Okay. Okay, sir.
Because that stooling may even cause premature contraction and premature labor.
Okay, sir.
Yes, somebody was trying to ask a question.
Can I have an input, sir?
Okay, yes, Dr. Bankole, thank you.
Yes, I think if you say you are stooling for days, several times in a day, I think you should also come to the hospital. Let's check.
Yes, sir. Thank you. Thank you. Go
It's not
Question, sir.
Yes,
Okay,
please,
sir.
madam, you need to go to the hospital because if you are stooling like that, one, you may be losing water and salt.
Okay, sir.
Which may be dangerous for you and the baby. Two, there may be an infection that you need to take care of.
Okay, sir.
Thank you. Thank you, Dr. Bankole.
Thank you, sir.
So, good morning, sir. I have a question, sir.
Yes, ma'am.
Yes, sir. Currently, I'm 38 weeks and few days gone now. So I went to the hospital for my usual checkup this week. We just ended. So the doctor checked me. I've been having contraction, like, because I stroll almost 3 times in a week. I stroll very well, but I've been having this really, really weird contractions, and I tried explaining to the doctor in charge that this is how I feel, and it's as if I lost my mucus plug too. Then I explained to him that this is what I saw, and I tried explaining everything to him. He checked me. He checked the baby too. I asked him to lie down. He checked the baby, checked me and my vitals. But I thought he was supposed to at least go further in checking the pelvic or the cervix or something. But he was just like, my baby and myself, we are okay, that I can still go home and come maybe next week again. Then I was surprised because I've been feeling contraction lately, even over the night, very strong contractions. So I don't know what else to expect.
Is the contraction painful?
Sir?
Are the contractions painful?
Yes, they are painful. Sometimes to walk is even the more I walk, the more I feel it, but it will go down again after probably 2 minutes.
Okay, is this your first pregnancy?
Yes, sir. This is my first pregnancy.
Okay. Have they done pelvic assessment for you? Have they checked your passage?
Not at all.
Okay. I know some people do it when you come in labor. I will just advise you that if you know that the contraction is becoming painful and becoming more regular, you should please go to the hospital.
Okay, sir.
Let them check, as you said, check the inside of you and see whether the cervix has started to open and to try to assess the passage and the passage.
Can request them to do all of this.
No, I just say you are having contraction and you don't know if you are in labor. That's all.
Okay.
Sir. When the doctor saw you, maybe the doctor look at your, your face and things, and I think that no, this contraction cannot be serious. Therefore,
Okay.
when you just say, I've been having this contraction and I don't know if I'm in labor, they will check, they will do all those things. They may not tell you, but when they check you, those are the things they will check.
Okay.
They
Okay.
will do a examination. They will look at the cervix and check the passage and the passenger.
Okay, sir. I'll do that.
Some people will, you know, when you're about 36, 37, 38, they want to do their pelvic assessment. But I know many a times when you want to do it, lady will say, no, it's painful at times, and therefore we do it when you come into labor. Because we know at that time it's compulsory that we have to examine you.
Okay, sir.
The contraction is becoming more regular and painful. Please go back.
Okay. Okay, sir. Thank you very much, sir.
Somebody wrote something, but I couldn't read it before it went off. He said, if somebody wanted to have CS, do you do something? Please, can you ask again?
Sorry, Dr. Olarewaju.
Yes, ma'am.
Okay, so my question is, okay, so at an expectant mother at 38 weeks, and let's say 3 days, then she goes to the hospital, let's say on a Wednesday, and she's told that she's already 2 cm dilated. How does she know, like, how would she know when to go? Because I was told to come back on Monday, that by Monday at least I should be fully dilated.
They don't expect you to be fully dilated at home. The thing is that your first baby.
Yes, sir.
You see, when you have delivered, the cervix is not completely closed.
Okay.
By the time you are pregnant again, there will be a small opening that you can put a finger. That's what they call multi-pause. That is not labor yet. That is latent. That's the one they say 2 cm. They just put their finger and say, oh, you are getting there. But because you have delivered before and it's not completely closed, they cannot say you are in labor. Therefore, what I'm going to say is this: since you already know how you feel when you're in labor, when the contraction becomes painful, go back. They don't expect you to be fully dilated at home.
Okay.
Immediately that thing passes about 3 centimeters. You know, now this labor, I'm sure they will have told you, we have 2 stages, or in fact, we have 3 or 4 stages of labor. The first stage is what we call latent phase. We have we have 3 stages of labor, but even in that first stage, we have 2 phases. We have latent phase and we have active phase. In the latent phase of labor, the cervix is still closed or dilated for about 3 centimeters. That one is still reversible. The contraction can still stop, and the labor may not progress. The second phase is from 3 centimeters to 10 centimeters, what we call fully dilatation. That one is what we call active phase. In the active phase, the labor is irreversible. The contraction may not stop again, okay? Unless there is a problem. And therefore, when you are in the latent phase, especially if you have experience, they may tell you, okay, wait. But I'm sure those who are in the latent phase, even if it's their first baby, most of the time they will be crying. They will be telling you the pain is too much. That's why they keep them in hospital. Okay? Your own may just be that latent, you know, the cervix just admitted a finger. And because you have delivered, they say you are not in labor. That cervix will be long. It will be soft, it will be long, not, you know, short, as we will say you are in labor.
Okay, but this is my first pregnancy.
No, that's why I asked you. I say, have you delivered before?
No, I haven't.
Okay, this is your first pregnancy.
Yes, sir.
Okay. And they did they do the vaginal examination for you. They say you are 2 centimeters.
Yeah, 2 centimeters dilated as at Wednesday.
As on Wednesday.
Yes, sir.
I'm sure you are not having good contraction.
The contractions they are more severe at night and early in the morning than in the afternoon. Like I can't sit, I can't lie down. So most times I just stack pillows and sit on those pillows all through the night. Then now try to sleep in the morning around say 9, 10.
Maybe because you sleep in the afternoon, that's why you're not sleeping tonight. But what I will say is, if those, madam, if the contractions are disturbing you, please go to the hospital.
Okay.
Yes, go there. Let them check you again.
Okay.
Okay, if you get there and they just say go home, I think you should tell them to call me. Yes, I will speak with them and find out what is happening.
Sir.
Okay, thank you.
All right, sir, thank you.
There's a chat. There's a chat. There's a question on the chat.
Yeah, I'm 22 weeks gone. Did my PCV yesterday? Oh, sorry, I didn't see it.
Sir, can someone that wants to do CS be allowed to wait till 39 or 40 weeks before it is being done?
Okay, it depends. As the person don't see CS before, if you have done CS before, the answer is no. Especially if you have had 2 cesarean sections.
She has done this before. She has had it twice.
No, we cannot, because we don't want to risk labor. And we know that people can go into labor anytime from 38 weeks. And we know that for somebody like that, the womb is very fragile. We don't want you to go into labor at all. Therefore, we don't advise you to stay for 38 weeks or 40 weeks. We do that cesarean section at 37 weeks or 38 maximum.
Okay, the next question. I'm 22 weeks gone. I did my PCV yesterday and it was 30%. Is it normal? Sir, because the last one I did was 36.
Okay. In our environment, a PCV of 36 or 30 is still normal. But in the developed country, the normal PCV is 33% and above. But in Nigeria and in the third world, we still allow 33. But that rapid decline from 36 to 33, to 30 is suspect. Therefore, the person like that, we need to check it again, because you don't want it to go lower than that. That decline was too rapid.
Hello, sir.
Yes, ma'am.
It was like 3 months ago that I did that.
Okay.
And it was 36 and now 30%. So
first time the one you did before was 3 months ago.
Yes, sir.
And at that time it was like you're about 8 weeks pregnant, Abby?
Yes, yes.
Okay. Your body at that time is still like you are not, the changes of pregnancy have not started setting at that time.
Okay.
But now you're already retaining fluid more than you are manufacturing blood. You see, what happened is this: during pregnancy, your blood volume, that is the water component, will increase by 40%. Whereas the concentration, the red blood cells, will increase by only 20%. Therefore, there is what we call hemodilution. So that when you lose blood during delivery, you are not losing all your red blood cells. You are losing blood that is already diluted. The compensation of pregnancy has set in now. But I want you to still watch it so that it will not go down suddenly more than this one.
All right, sir. Thank you, sir.
Thank you.
Can I take ORS, spend the time I go to the hospital because of the watering stools? I'm 34 weeks gone.
Oh, yes, the woman that is having that diarrhea, yes.
Yes.
Please, yes, please take ORS, but don't wait till Monday. Go today.
Okay, I'm 35 weeks gone, and I notice I've not been eating like I used to. Neither am I hungry that much.
Yes. The tummy is very big now. If I were you, I won't be hungry also. I think, yeah, I'm just joking. I'm just joking. Actually, what is happening is that the pressure, the baby's, the pressure of the womb may be compressing your stomach, and it will limit the space that is available. What you need to do is to eat little at a time, but eat more frequently. Don't go and eat, bulk as you used to eat. Just eat little. Look at what you want to eat. Eat little, but eat more frequently, because the baby still needs those nutrients, and you need it also.
I'm 37 weeks. I had a case of ectopic surgery for ectopic pregnancy. When I went to the hospital, they said I can deliver through vagina. Hope it is safe.
Ectopic is not an indication, it's not an absolute indication for cesarean section. If the pelvis is okay and the baby is all right, everything being equal. But you see, nobody can say everything will be okay until you have delivered. A normal delivery is diagnosed after you have already delivered. Therefore, I will advise your doctor and yourself to be very, very careful, to pay attention very, very well, because you have one tube. But strictly speaking, that's not enough to say you must have CS for all your deliveries.
Sir, I'm 26 weeks gone, and I sometimes feel pain around my pelvic area. Should I be worried?
You say you have pain at the pelvic area?
I'm 26 weeks pregnant. And sometimes I feel pain around my pelvic area, pelvic bones. Should I be worried?
I don't think so, depending on what is causing the pain. If sometimes most of the pain you have in your pelvic area is just usually due to the pressure, because the baby's head is there, and 36 is advanced. The baby's head is pressing on some of those things, and then your weight. You remember that your weight has increased, and it's your leg and your pelvis that is bearing the brunt of that weight. Therefore, all those things may combine to make you to have some pain, but make sure that they are the cause. Let the doctors examine you and tell you everything is all right. But the woman who had ectopic, I want to add something. If you are old, if you are advanced in year, if you have had infertility for a long time, if this is your first baby and you are already, getting to the other side of life, it's better to go and take that baby out too. Therefore, there are so many things that are attached to it.
Better to do CS, that's what you mean.
Yes. It's better to just go and do CS if there are other complications apart from ectopic, because you don't want to add two complications. That is, ectopic is one. Assuming you have diabetes, they must section you. If you have hypertension, don't wait. If you have abnormal, baby is lying abnormally, don't wait. Therefore, everything must be okay.
If you have prolonged infertility, don't wait.
Yes, if you have prolonged infertility, don't wait. If you are old, if you are 45, don't wait. Thank you.
Does Mother and Child Hospital do water delivery?
No, we don't do water delivery.
So I'm 27 weeks. I checked my weight yesterday. I'm 90 kilograms. I was 76 kilograms before pregnancy. Baby weight as of yesterday was 1.065. So baby is not big. I'm bothered about the weight gain. I still have 13 weeks to go. I don't want to keep gaining more weight. What can I do?
You have already gained 14 kg. And the baby is 1 point something. Then where is the weight coming from? That's dicey. What's the blood pressure? The person may be retaining fluid. May be retaining fluid. The blood pressure must be known. The trust is not, there's no issue and things like that. I think that's the sort of person should be.
If you are registered with Mother and Child, come to Mother and Child.
Yes, the person should be assessed properly, because that weight is getting the average weight gain in Lagos area. I know the time when I did a study in Jos, the average weight gain in Lagos area is 10 to 12 kg. Therefore, that one is already high, and you still have many weeks to go. Therefore, please come for proper assessment. Come and see me on Monday.
I'm 36 weeks gone, and I just stopped adding weight. Last checkup, I was 104, 2 weeks checkup, still 104. I don't know if it is normal. I don't know what it means by 104.
104 kg.
Ah. Okay, all right.
At that person, they try. Yes, the weight, you see, weight gain in pregnancy is also a contentious thing. Some people will gain much, especially when they are underweight before. And some people will even lose weight if they are overweight before. Therefore, if you are 36 weeks and you are 104, you have tried. And weight may not increase after 36 weeks. Therefore, just let them keep a close watch on the baby and yourself. I think that's okay. But ladies and gentlemen, our time is done. It's after 11. No?
I did my sugar test.
Can we continue?
Let me just read this too, and then you answer. I did my sugar test, and it reads 111. Please, is there a need to worry? I am 34 weeks. And the next one, the final one is blood pressure is fine. My blood pressure is fine. The same person.
Blood sugar is 111. It's normal.
Okay. They are just coming in. Another one. Can I read this last one? I'm 17 weeks gone, and this is my first pregnancy.
Please
I want to
keep
know
on reading.
I want to know if I can take other drugs like pregnant care drugs, aside from the ones being given to me at the hospital.
Yes, if you want to, 17 weeks, the one we give you in the hospital is adequate. But if you want to take, then you can. We don't want to be discussing those drugs. I don't want any company to sue me. We don't want to be discussing them on the, in the air like this, a public space. But the one we are giving you in the hospital is okay. But if you take it, it's good. You will just eat more. That's good. Because it has some modifier that will improve your appetite also. Yes.